Thank you for inviting me to present to you all. And it's so wonderful to be able to share the research where we've used so many of your tools in our research. So my name is Dr. Hazel Keedle, and I'm a senior lecturer of midwifery at Western Sydney University. It was really interesting to hear your land acknowledgement and in tradition of our practices in Australia, we do an acknowledgement of country. And I put the First Nations people up there. I'm actually from Parramatta, which is a city in Sydney's Greater West, and we recognise the Darug people as traditional owners of our land. And since I work there, and that's where our research has come from, I wanted to give acknowledgement to them alongside acknowledgement to the people of the traditional owners of the land that I'm here in Vancouver. And I love this picture of Vancouver because actually Parramatta is on the Parramatta River, the land of the Burramattakal clan, although we don't have mountains in that particular river. Okay, so the information I'm going to tell you about today is from the birth experience study, which you may not have heard of before. It was a cross-sectional national online survey that started back in 2021. It has about 130 questions, including some validated tools. So we have the measurement of decision-making, the measurement of respect, and the mistreatment index. We also have one on continuity of care as well. But then there's a lot of other questions in there with closed and open text comments. So in our survey back in 2021, where we had just under 9,000 completed responses, we also had a lot of comments to go through as well. So we had 26 open text comments and over 54,000 responses to those 26 open text questions. It was a co-designed survey or study. So what that meant for us was that we worked with organisations, consumer organisations. Now in Australia, we've got quite a few maternity consumer organisations. So we reached out to them. We had a very short time to get this going. The history is that it was a documentary that was being released, and they reached out in the January to say, it'd be great if we could have a small survey to go along with our film called Birth Time. And they were releasing that in March, and it was now January. So we had a very short time to get it done and through ethics, but we did it, and we got it done in time for their filming. For the release of their film. But we worked with consumer organisations, and they helped us design the survey. They've been part of every single step of the research process. So far, just from Best Australia, we've had 7 papers published, one very recently, just as I was travelling recently. That's the debriefing, the content analysis of women's experiences of debriefing. So many of these have been in response to one of the open text comments, and then we've done a content analysis of that. We've also started, our very first paper was a poetic inquiry that we used, and Pixie Willow, who's the second author there, is a poet, a published poet, and she used found poetry, so using the women's words to create poems. And then we looked at just specifically the birth trauma ones, and we published a paper on that. But there's a variety of ones there, including the one up there in the corner on obstetric violence, which is what I'm going to be talking about today. We've got one more under review, and then that will make 8. And then we're planning on repeating our survey in next year. So then we'll start it all over again as well. But we didn't just stop with our country. We actually reached out to other research groups around the world, and a lot of them reached out to us to use our survey. And we have some aims and objectives of the international collaboration, which is, a part of it is paying it forward in the time that we've spent. So we've created this big survey, and some of it was already translated in 7 languages when we put it out across Australia, but then it's gone through other translations. And we now have data from 5 countries. So that's Australia, the Netherlands, Denmark, Sweden, and UK. Indonesia is about to launch theirs. They're just hot off the press. They'll be launching theirs in May. And then we've got varying research groups at different stages of theirs. Some are trying to find funding before they can get started, and others, like I said, have already got data. Our biggest data set so far is from Sweden, where the Karolinska Institute partnered with us and with Marlin, and they received over 17,000 responses. So it's growing, and we're working on 4 collaborative papers at the moment, really having a look at the top issues that are important to all those 5 countries involved. So I'm going to focus in on obstetric violence, but where I see obstetric violence is sitting under that umbrella of birth trauma. And so women who experience obstetric violence have experienced a traumatic birth. But birth trauma can mean other things as well, and it can include obstetric violence and other experiences too. We found it, so in our survey, we asked if you had experienced a traumatic birth, and 28% of women said yes in Australia. Now, we covered all states and territories, including little Tasmania off the south coast, and I think that is quite representative because it is what we expect in a lot of birth trauma research, around about that third, so it's just under that third. There are some quotes as we go through this presentation that women actually have put into the survey. We did use the mistreatment scale, which was really interesting. It was my first time using that. I have used your decision-making and respect index, but I hadn't used this before. And this was quite interesting to look at because it scored higher than our birth trauma rate. And I think because when we just say, have you experienced birth trauma, that can be quite confusing, and people maybe not know what does that even include, whereas I think the MIST is good because it just lists them all. So we found that 35% of women in Australia experienced at least one type of mistreatment. The highest one was feeling ignored by clinicians, but there was still 2% that experienced that physical abuse as well. And I had put that 77 respondents in New South Wales because we used this. This has come from the report that we put forward into an inquiry that I'll tell you about later. So obstetric violence, we did ask the question on obstetric violence, and that was because we were asked to by one of our consumer organisations. So Human Rights in Childbirth said, can we ask a question on obstetric violence? So we did, and we said, did you experience obstetric violence? We put a definition in there so that women could maybe get a bit of an understanding of what that was. And then there was a yes, maybe, or no. This is one of the only ones we put a maybe in there because we knew that we thought it wasn't a term that was really understood in Australia. So we wanted to include women that were not quite sure and thought maybe they had. Then and so from that one question, it was around about 11%, so just over 1 in 10 women reported that they had experienced obstetric violence. We then did so if they asked that question, if they said yes or maybe, they then got led into an open text question, which was asking them if they could describe that experience. And I really do acknowledge the women that did do this, because it would have been potentially really re-traumatizing potentially to put these stories back in there. And they really did share what happened to them. And so 626 women left comments around their obstetric violence experience. Now, when we closed the survey at the end of 2021, I was really interested in these comments because we hadn't asked this before. And they were so deep, and I feel that women gave so much of themselves into even putting those comments in there that we did focus on this one as our first analysis paper. We got this one out there because we really felt that we should do justice to the women that shared their stories. When we then analysed the 626 comments, we realised that there were 3 main categories, and that was I felt dehumanised, I felt violated, and I felt powerless. And the more that I have learnt about this, I think it's more, I think this is a process even that as clinicians see the woman as dehumanized and powerless, then I think it potentially has a breeding ground for violation. Now I'm going to go through some slides next, and I will give you some comments, but this is how the breakdown of the content analysis was, and we used qualitative content analysis. You can see the main categories and then the subcategories. So in that dehumanized main category, it's a lot about that the disrespect and the abuse, the feeling like you're just a cog in a machine or just a number, being dismissed for their pain, and then the ongoing trauma, and for both of us. So the women did explain that this impacted their partners or the support people as well as themselves. I'll jump down to the powerless one. So although that was the smallest category, that had comments around coercion, so being told if you don't do something, something bad might happen, like, your baby might die, that there was, that they felt that they were uninformed or misinformed. And they often felt this after the event when they looked back and explored some more and felt that maybe they were given the wrong information or that they were forced into interventions. Then the violated, obviously these were really quite challenging ones to look at. One of them was all about vaginal examinations, and that was fingers were inserted into my vagina without consent. Physically manhandled was the physical side of maybe being pushed down onto the bed, having your legs pushed up against you, having really forceful fondle rubs, or even having the breasts grabbed during breastfeeding. And then I begged the doctor not to cut me. Unsurprisingly, that's all about episiotomy. So there was an entire whole subcategory just on that. So I'm going to give just a trigger warning because the comments that you're going to see next over just the next 5 slides only, so you can look away if you like, and also some words on the 5th slide are quite powerful comments. So this one goes into the dehumanized category, and I think this one is really quite I think they're all concerning, but this one is that we don't even need to know what the procedure was. It was the fact that she wasn't given any choice, that they didn't pause or check her consent. There were strangers in the room and she was exposed, and that she felt that the midwife had joked about the procedure, and that all of that is what she described obstetric violence as. The next one is really focusing on that dehumanization as well, like they're just a number, but feeling like she was just a vessel, that they just didn't care what was done to her. It was just about getting that baby out, that she was just that carrier of the baby. This is one of the powerlessness ones, looking at the coercion. And so here she was saying that she was offered the intervention over 6 minutes. And she finally said yes when she was coerced by getting on her back. And she feels that she didn't actually give informed consent. It was more a coerced consent and almost just like a giving up to get this person to stop doing that. And then this one is obviously about the violation of a very long vaginal examination and being held down, and just saying no that whole time. It's really quite a distressing comment, that one. But this is what we had. This is 626 comments really going into depth on what the women felt was obstetric violence. Then also in that, in the vaginal examination subcategory, if we look at that, just that alone, these were a lot of the words that were used describing this vaginal examination, which is something that, clinicians can see as a routine process, or a routine examination can actually be something that can result in a sexual assault. And when we wrote the paper on this, we did talk a lot about the sexual violence nature of obstetric violence, and that hadn't been mentioned quite as much in a lot of the literature that I looked at. And this quote's really good. Again, she doesn't need to talk about what happened. She just describes it in the relation of the Me Too generation, and the impact that then had for her, and how she doesn't see that it was any different, even though she didn't need to tell us actually what happened. Okay, we'll take a breather. We've gone through those hard comments. So obstetric violence has many different definitions. We know that it's recognised by the United Nations as a form of gender-based violence. And then in recent documents from last year and the year before, we've got the European Union talking about obstetric violence, and the International Confederation of Midwives. That bigger quote, the one that says it includes physical violence, loss of autonomy, I think that's a really good quote to use. It's a very comprehensive quote. And actually, when we look at a lot of the comments that the women said in Australia, they do match this. However, I'm not quite sure where the vaginal examinations would fit in this, other than it being physical violence. I do think we need to maybe be a bit more cognizant about the sexual violence part of it as well. Because, there is, the non-evidence-based practice such as routine episiotomy, but it doesn't quite go into what the women were saying to us about their vaginal examination experience. But there's some good quotes there, and looking at, obstetric violence has got a very long history, and I haven't got time to go into all of that, and I'm sure many of you know it anyway, knowing that it came from, through South America and the work that has been done. Now, with our survey going global as it has, we were going to be collecting some really interesting data on this. We're going to be able to see it from different perspectives and from different countries and continents to get an understanding of what women say it is and how they describe it. And I think that'll be an important part. And especially in some countries where this hasn't been asked before and actually had never been asked in Australia before. So then I want to talk to you about what did it do then in Australia? So, we put out papers, we hope it makes some change, but we don't often know the impact of that. But in Australia, we did. So part of the co-design, working with our consumer organisations, meant they were kept updated once we were in the analysis and the publication phase. And we told them about papers as they were being submitted, as they were being accepted. And we told them that the obstetric violence paper had been accepted. There was a bit of a delay, however. It was accepted in the August, didn't get published till early online view until I think it was the November or December of 2022. So, and then it's the final version, I think actually has a date of 2024, but the early online was at the end of 2022. But middle of that year, we had told our consumer organisations that this was happening and this was going to be coming out there. And some of them were trying to get some political interest in this. And one of them, I think it was Maternal Health Matters, and would have been their consumer organisation, was cold emailing politicians in our state of New South Wales, which is not one of the biggest geographically, but certainly the most population-based states. And that's where Sydney is. And she was CCing me in these emails because she was talking about the paper, and one of the politicians from the Senate in New South Wales Government was interested, and she wrote back saying, can you tell me some more information about this? So that's where I jumped in, and I said, oh, well, let's have a chat about it. And then we arranged a meeting on our university at Parramatta campus with Professor Hannah Darlin, who's my co-researcher and long-term mentor and friend, and Bashi Hazard, who is she's now Dr. Bashi Hazard, who's a human rights lawyer she's now at University of Sydney. And so we all came together to discuss it with the politician. That was Emma Hurst, and her background is animal rights, but also actually she's very interested in women's health, and she's a psychologist before she became a member of the Senate. So she wanted to learn a lot more about this. And then there were lots of things that happened. There was a group complaint from a very regional town in Australia called Wagga Wagga in New South Wales as well. There was a complaint from 30 women, and they worked with Intended Consumer Network to put that complaint in. And we had a change in government. So we went from a more conservative government in New South Wales to a Labor government, which is a more progressive government we see in reproductive health work anyway. So with all that changing, Emma, at one point, we had talked about things that could happen, and she put forward to the Health Minister and the Premier of New South Wales that we should have an inquiry into birth trauma, and it got approved. And this was the first time this had ever happened in Australia, and in many places in the world it hasn't happened either. And so in the terms of reference, which I was really holding my breath for at the time when I knew this was happening, they did actually include obstetric violence. As you can see in this top little one here, they mentioned obstetric violence. So it was there, right there in the terms of reference. And then in the final report, so then the birth trauma inquiry opened, they had over 4,500 submissions from across Australia, but certainly within New South Wales as well. One of the largest public submissions I've ever seen. It was a really big thing at the time. I'm not sure if you heard about it over here, but it was big. It was on the news. It was all over social media. And then they had, I think it was 6 or maybe 8 hearings where they did, majority of them in Sydney, but they also travelled to a couple of regional locations. I gave evidence alongside Hannah. We gave evidence in the first day of the hearings. And I was also, before the hearings, I went along as their expert in midwifery, where myself and trauma-informed care practitioners talked about how they should even run the hearings so that they don't re-traumatise women. So then a year later, we get this report, and they kind of skirt around the term obstetric violence, but they do say that women have recounted they've experienced birth trauma as a form of violence. So there's a bit of inclusion there. I'll give that one a tick. But then our New South Wales government have to make a response, and that was our health minister. And in that response to all the recommendations that were given, there was absolutely no reference to obstetric violence at all. Now, I will just add that in that report, not the response, but in the report, Emma Hurst, who was the chair of this, put a dissenting comment at the end of the report, which is a really interesting part. And she wanted to say that it be a form of gendered violence and use the term obstetric violence, but the rest of the select committee would not agree to that. So that's an interesting little bit that came in. But there are now no further movements now in New South Wales because the New South Wales government didn't even bring it into their responses. So where do we go next? That's a very good question. One thing I also just want to go over as well is that we do need to recognise, I think, from our data, that the cascade of intervention partners, and we know so much about the cascade of intervention, right? But I think it partners with that cascade of trauma. So what we did for the birth trauma inquiry is we put together a report. We didn't have time to put to do a lot of in-depth analysis. So this is very basic descriptive statistics that we had to put together so that we could put a report into the inquiry. So that's some of the stuff we're going to look at next. So one of the things we looked at was an onset of labour and trauma. So you can see here, so if we remember that our base level was 28%. So we can see that women who were induced and experienced birth trauma, that went up to 38%. Women who had spontaneous labour went down to 23%. And I'm not quite sure about here in Canada, but we have an induction epidemic going on, I think, in many of the countries involved in BEST, and definitely in Australia. Every morning, the women will be lined up ready for their induction. And, you know, we know some of the studies that have caused that, but there's not really been much input on women's experiences of this. So we can see, though, if they had been induced, there were high rates of birth trauma. The other thing we looked at, which I think is a little bit radical, but we looked at mode of birth. And the only one that kept it the same was elective. The only one that reduced it was spontaneous vaginal birth. And then both instrumental and caesarean during labour were right up to that 55%, 57%. That does match what I did for my PhD, which was on vaginal birth after caesarean, and I did a national survey. And I asked women if they'd experienced a previous traumatic birth. Now, remember, slightly different cohort of women. These are all women who had a caesarean and had planned a VBAC. And that was, I think, 69% of women said that their previous caesarean was traumatic. So, you know, really quite interesting high rates there. The other thing we looked at was how the models of care impact birth trauma and obstetric violence. And I've also got MIST in there as well. So just a quick understanding of what those different models of care are. We've got standard care, which is just standard fragmented. The woman turns up to antenatal clinics, sees a different midwife or doctor each time, different in labour ward and also in the postnatal ward. GP is they'll see maybe a community doctor or general practitioner during their pregnancy, but then they're dumped into the same standard fragmented model for the rest of their antenatal, labour and birth and postnatal. Private obstetrician is when they see a private obstetrician and they may have access to a private hospital for that. And then MGP is midwifery group practice in a public hospital. So they get continuity of care with a midwife for free in the hospital, but they are bound obviously by hospital guidelines and policies. And then PPM is a privately practicing midwife. I've just been in the US, they called that community midwives, but they have different qualifications, I know. But these are privately practicing midwives, so they're registered midwives who've then taken extra qualifications, and they're mainly providing home birth. And it's definitely continuity of care. And I can speak to probably a lot of them, other than the private model. I've worked in all of those models. So if we then look at how do we rate with obstetric violence, birth trauma, and mistreatment scale, the ones that go above the standards that we have are the fragmented models, and the ones that go below the baselines are the continuity models. But not all continuity models are the same either, and you can see the differences between private obstetrician, MGP, and privately practicing midwifery. I think the discrepancies in the MGP is because both the private midwife and the private obstetrician are much more autonomous, whereas the MGP midwives are bound by a lot of the hospital practices. If we just remember the mode of birth and then the model of care, and we put those overlay the two, we can see that MGP and privately practicing midwives have much higher vaginal birth rates, which is the only one that reduced the birth trauma rates. Hope everyone's still following along okay. So one other thing I wanted to go through was we looked at, again, because of the terms of reference, and the terms of reference for the inquiry wanted to explore birth trauma in different groups, such as young mums, First Nations women, culturally diverse women. And so we looked at what we had. Now, there's quite a few groups that we didn't ask questions about in the first survey, but we are changing that in many of our international ones and certainly in our next version. So we will be asking questions about neurodiversity and women and birthing people who represent the LGBTQI plus community. We didn't ask those questions the first time round, and I admit we didn't get everything right. But we are asking those, especially in the UK version that was done last year, there was all of those questions are in there. We didn't ask about disabilities either. So let's look at the ones that we did know. So in the Mothers on Measure on Respect Index that you guys have, we sent that out to, when we were designing our survey, we sent it out to our consumer group and they added extra items. Now, we didn't include those extra items when we were doing any scoring, so we didn't change the scoring, but they wanted them in there. And one of them was BMI and a higher BMI. I think this is one of the added ones, and you can correct me if I'm wrong there. So I pulled just those women that felt, so they already felt disrespected because of having a higher BMI. And then we can see that, unsurprisingly, they then have much higher rates of birth trauma, 45%, and 1 in 4 experiencing obstetric violence compared to 1 in, 1 in 10. Young parents probably had the worst experience or the highest rates of birth trauma from the subgroups of women. And we're working with a young mums organisation to really look at the content from this. And this quote, you know, if you're reading that quote and just imagine, right, how young this person was. So they've got the age range, but then they could have had the baby in the previous 5 years. So she was younger than that original age range. I didn't look up this particular person to see when they had their baby. Well, I could have done, but I didn't, for anonymity. But just looking at that, you know, being real past naked from past the front where visitors are to a birth suite, you know, that would be horrifying enough, however old you are, but particularly when you're young. And I've got teenage daughters right now. And, you know, the lack of support, and then not being able to really look at her video and being, you know, re-traumatized when she's watching her video. And, you know, 41% experiencing birth trauma and then higher rates of obstetric violence too. We do have an issue of racism in healthcare, most definitely in Australia. And our First Nations women have a difficult time in our health system and then also in our maternity care. There's a real lack of cultural safety. And there's a lot of things we're doing to improve it, such as birthing on country models and continuity care models specific with First Nations midwives supporting First Nations women. But no way is that nationwide, and no way is that for every woman. So here, again, you can see higher rates of birth trauma and higher rates of obstetric violence and a real lack of cultural understanding in that quote. For culturally and linguistically diverse women, that's a term that we use in Australia. And like I said, we did translate it into different languages. Again, slightly higher birth trauma and obstetric violence rates as well. Although we did do the translations, I will be honest, we didn't get as many communities, diverse communities that we were hoping, but we also didn't have a lot of contacts at the time. We tried to, we certainly tried very hard to, but this time round we have, and in the time from the first survey to now, I've been working very hard at getting lots of contacts and organisations and groups that do support women from different diverse communities. And so fingers crossed we might get better at getting more CALD women. But one of the other things we're doing is looking at women in other countries and then thinking, how does that impact them when they migrate? I think that'll be interesting with some of the work we're doing with Indonesia. We had one particular paper we looked at where we asked women in the survey if they had experienced intimate partner violence, and then we looked at their outcomes, and that paper is currently under review. And I did that with a psychology honours student. She did this for her honours project. And so we looked at specifically at the the madam mistreatment and a few other outcomes, quite a few other outcomes. But we did also notice that they're experiencing more trauma and more obstetric violence too. And we may not have the answers for this, but we can certainly identify that it's an issue. Okay, there's the paper, which is all the qualitative comments, and that's written by myself and by my husband, who's also happens to be my research assistant, which is, you know, a really great working relationship. And Hannah, darling, and I really must give a shout out to Hannah, who has been my, my inspiration for everything that I do, and was my supervisor for both my master's and my PhD, and then has supported me in this birth experience study as well. And she has a particular interest in the induction work that we do from the birth experience study. So yeah, that was just the three of us who wrote that. And it was a tricky paper to write. We had to do a lot of reflection from ourselves because it's never easy to do that. But obviously we always held at the front that it's us rereading them and analysing it is never as difficult as experiencing it in the first place. So we wanted to do the women justice and honour in what we were doing in reporting their stories. And that's me. I'm not sure how I've gone with time, but hopefully we've got time for questions. But this is me, so do stay in touch. I love communicating on Instagram. That's where I put a lot of the papers and the reels. I mean, the last few reels are just about my travel to the US and Canada, but that's where I put all my student papers and my papers. So feel free to follow me there. There's my email, but also we do have a website, birthexperiencestudy.com, very easy to find. And that's where you can see information about the different countries. It's where we put all the papers and they're all open access except for the poetry one. And if you need that one, you can't access it, please let me know and I'll email it to you. But yeah, that's a great website. You can see that we're now over 35,000 as our number at the moment, and that's just growing as more countries do it. And you can also contact me through that website as well. And that's me.